growth through trimesters. It's quite a broad topic, but I think Dr. Alinsha Maharaj has done a great job trying to put things into perspective for all of us. So I'll hand over to her, then we'll take the comments and questions at the end.
Good morning, everyone. And like Dr. Kumalo said, our topic for discussion today is understanding fetal growth through the trimesters. We'll be going through the introduction, the stages of development, velocity of growth, factors influencing growth, the assessment of growth, the challenges we face with fetal growth, management, and obviously we'll finish with our take-home message. Fetal development is a dynamic, complex process that unfolds over approximately 40 weeks. This is divided into 3 trimesters. Each trimester marks critical milestones in the growth and formation of organs, systems, and physical structure. Fetal growth directly impacts perinatal outcomes, and deviations from the normal, whether restricted or excessive, can carry significant clinical consequences. These trajectories of fetal size and growth are important indicators for fetal health. So, why is it important? Monitoring fetal development helps to ensure a healthy pregnancy and early detections of complications. Our prenatal development produces many ramifications affecting our health, hence making the study of embryology and fetal development an important topic for all healthcare professionals. So to define the period of each trimester, first trimester is from the first day of the last normal period up until 13 weeks and 6 days of gestation. This includes the embryonic and the initiation of the fetal period. The second trimester is between 14 weeks to 27 weeks and 6 days, and this is the continuation of the fetal period that occurs in this trimester as well, up until birth. The third trimester is from 28 weeks to 40 weeks and 6 days. So the pre-embryonic period is usually from week 1 to week 2. Development begins with fertilization, the process by which the male and female gametes unite and give rise to a zygote, and is completed by implantation. The embryonic period, which is week 3 to week 8, is also known as the period of organogenesis and is the time when each of the 3 germ layers give rise to a number of specific tissues and organs. By the end of the embryonic period, the main organ systems have been established, rendering major features of the external body recognizable by the end of the 2nd month. This is a period also of high vulnerability to 2 teratogens. The fetal period, which is usually from week 9 to birth, is the period which is characterized by the maturation of tissues and organs and rapid growth of the body. In preparation for fertilization, both male and female germ cells undergo gametogenesis, which is the maturation from a primitive germ cell to mature gametes and includes meiosis and cytodifferentiation until a mature gamete has a haploid number of chromosomes with the sex chromosome, either 22 plus Y or 22 plus X respectively. Oogenesis occurs before birth after repeated mitotic divisions. Some of these ogonium arrest in prophase of meiosis 1 to form primary oocytes. By the 7th month in utero, nearly all ogonia have become atretic, and only primary oocytes remain surrounded by a layer of follicular cells derived from the surface epithelium of the ovary. Together, they form the primordial follicle. At puberty, a pool of growing follicles is recruited and maintained for the continuous supply of primordial follicles. Thus, approximately 15 to 20 follicles begin to grow, and as they mature, they pass through 3 stages: the primary or pre-antral stage, secondary or antral stage, and the pre-ovulatory stage. The primary oocyte remains in prophase of the first meiotic division until the secondary follicle is mature. At this point, the alate cell stimulates the pre-ovulatory growth, and the secondary follicle and polar body is now formed. The second oocyte now arrests in metaphase of meiosis 2, approximately 3 hours before ovulation, and will not complete the cell division until fertilization. Spermiogenesis, on the other hand, begins only at puberty, where we have the primordial germ cell differentiating into spermatogonia. These stem cells give rise to primary spermatocytes, which through 2 successful meiotic divisions produce 4 spermatids. These spermatids go through a series of changes known as spermiogenesis. So this picture depicts the process of ovulation and fertilization. Like previously described, preceding ovulation, under the influence of FSH and LH, the secondary follicles grow rapidly to a diameter of 25 millimeters. The LH surge causes the primary oocyte to complete meiosis 1 and the follicle to enter the pre-ovulatory stage. Meiosis 2 is now initiated and the oocyte arrests 3 hours before ovulation. Parallel to this process, the surface of the ovary starts to bulge at the apex. An avascular spot known as the stigma forms. High concentration of LH increases the collagenase activity, resulting in the digestion of collagen fibers surrounding the follicle. There is also an increase in the prostaglandin levels, and this causes a local muscular contraction effect on the ovarian wall that extrudes the oocyte, which cells rearrange around the zona pellucida to form the corona radiata. So with regards to the transport of the oocyte, this occurs at the fimbrial aspect of the tube. So once the oocyte is released, the fimbria gently sweeps across the surface of the ovary, and the fallopian tube itself has this contractile motion that assists with the ciliar motion of the epithelial cells to help with the process of transportation. Once inside the tube, these cumulus cells withdraw their processes and release itself from the zona pellucida. The oocyte is now propelled further by the cilia, and this rate of transportation is regulated by the endocrine status during and after ovulation. With regards to the corpus luteum, after ovulation, granulosa cells remaining in the wall of the ruptured follicle, together with the cells of the theca interna, are vascularized by the surrounding vessels. And under the influence of LH, these cells now develop a yellowish pigmentation and change to lutein cells, which form the corpus luteum, and starts to secrete progesterone. This hormone, in conjunction with the estrogenic hormones, now influence the uterine mucosa to enter the progestational or secretory phase in preparation for implantation of the embryo. Next step, fertilization. This occurs in the ampullary aspect of the fallopian tube, and only 1% of the sperm deposited into the vagina enter the cervix. The trip from the cervix to the oviduct requires a minimum of 2 to 7 hours, and after reaching the isthmus, the spermatozoa now become less motile and cease their migration. They are unable to fertilize the oocyte immediately upon arrival and must undergo capacitation and acrosome reaction to require this capability. The phases of fertilization include penetration of the corona radiata, penetration of the zona pellucida, and fusion of the oocyte and sperm cell layer membranes. As soon as the sperm enters the oocyte then responds by cortical and zonal reaction, resumption of the second mitotic division, and metabolic reactivation. After both male and female pronuclei have replicated, these chromosomes intermingle, split longitudinally, and go through a mitotic division, giving rise to a two-cell stage. The results of fertilization are restoration of the diploid number of chromosomes, determination of the chromosomal sex, and initiation of cleavage. Cleavage is a series of mitotic divisions that result in an increase in cells. After 3 divisions, the blastomeres undergo impaction to become a tightly grouped ball of cells with an inner and outer layer. These compact blastomeres divide to form a 16-cell morula. As the morula enters the uterus on the 3rd or 4th day of fertilization, a cavity begins to appear and the blastocyst forms. The inner cell mass, which is formed at the time of compaction, will develop into an embryo proper at one pole of the blastocyst, and the outer cell mass, which surrounds the inner cells at the blastocyst cavity, will form the trophoblast. The uterus at this time of implantation is in the secretory phase, and the blastocyst implants in the endometrium along the anterior and posterior wall. At the beginning of the 2nd week of development, the blastocyst is partially embedded into the endometrial stroma. The trophoblast differentiates into the cytotrophoblast and the syncytotrophoblast layers. and the lacuna develops, with the maternal flow now entering the lacuna network, and the primitive uteroplacental circulation now begins. Primary villi form, and we have the bilaminar disc being formed by the epiblast and the hypoblast. The amniotic cavity develops, and the exochorionic membrane surrounds the primitive yolk sac. Formation of the chorionic cavity also occurs, and the extra embryonic mesoderm lining the cytotrophoblast and amnion is extra embryonic somatotrophopluric mesoderm, and the lining surrounding the yolk is now the extra embryonic splenic pluric mesoderm. In summary, the second week of development is known as the week of twos. The trophoblast differentiates into 2 layers, the embryoblast forms 2 layers, the extra embryonic mesoderm splits into 2 layers, and 2 cavities are now formed, the amniotic and yolk sac cavities. The main characteristic event occurring during the 3rd week is gastrulation, which begins with the appearance of a primitive streak and primitive node. In the region of the node and streak, epiblast cells move inward to form new cell layers, the endoderm and the mesoderm. Cells that don't migrate through the streak and remain in the epiblast form the ectoderm. The notochord is formed, which serves as a basis of axial skeleton, and the hypoblast at the cephalic margin of the disc form the anterior visceral endoderm, which expresses head-forming genes. By the end of the 3rd week, tissue and organ differentiation has begun, and it occurs in a cephalocaudal direction as gastrulation continues. The trophoblast progresses rapidly, and primary villi obtain a mesenchymal core in which small capillaries arise. When the villus capillaries make contact with the capillaries in the chorionic plate, the connecting stalk, the villus stem system is now ready to supply the embryo with its nutrients and oxygen. So this is just a summary of the embryonic germ cells and what they develop into. The ectoderm itself, hair, skin, nails, the brain, the blood vessels of the head and neck. The mesoderm, the vertebra, ribs, dermis of the ventral and dorsal body region, trunk, limbs, kidneys, the gonads, connective tissue of limbs, the wall of the respiratory and digestive tract, visceral and parietal serosa, the heart and blood vessels, and the endoderm, the epithelial lining and glands of the digestive and respiratory tract, as well as the formation of the liver, pancreas, thymus, and the thyroid and parathyroid glands. The period of organogenesis is from week 3 to week 8, and by the end of this period, the main systems have been established and major features of the external body form becomes recognizable. This is a result of the formation of the organ systems and rapid growth of the central nervous system. The initial flat embryonic disc begins to fold cephalocaudally, establishing the head and tail fold, and the disc also folds transversely, establishing the rounded body form. The fetal period now begins from the 9th week up until birth, and again, this is characterized by the maturation of tissues and organs with the rapid growth of the body. Growth in length is particularly striking during the 3rd, 4th, and 5th month, while an increase in weight is most striking during the last 2 months of gestation. At the end of the 10th week of growth, bone ossification begins and the kidneys begin to excrete urine. From the 12th week, the face becomes more human-like, with the eyes moving to the ventral aspect of the face, the ears come to lie closer to the definitive position on the side of the face, and the limbs reach their relative length in comparison to the rest of the body. Primary ossification centers are now present in the long bones and skull, and external genitalia develop to such a degree that the sex of the fetus can now be determined by external exam. The intestinal loops withdraw into the abdominal cavity, and from week 16 onwards, the fetus grows rapidly in length, and at the end of the first half of uterine life, the crown rump length is now 15 centimeters, almost half the length of a newborn. The fetus is covered with lanugo hair, and movements or quickening is now felt by the mom. During the second half of uterine life, weight increases rapidly. The skin of the fetus is reddish and appears wrinkled due to the lack of underlying connective tissue. The bronchioles and primitive alveoli are now forming. During the last 8 weeks, the fetus obtains the well-rounded contours as a result of an increase in subcutaneous fat, and by the end of the intrauterine life, the skin is covered by vernix caseosa, and surfactant coats much of the alveoli epithelium. At the end of the intrauterine development, the skull has the largest circumference to all the parts of the body. And at the time of birth, the weight of a normal fetus ranges between 3,000 grams to 3,500 grams, and its crown rump length is 36 centimeters, or its crown heel length is 50 centimeters. Here is a summary of the key events occurring in the embryonic period of development. Like we've mentioned already, the ectoderm germ layer gives rise to the central nervous system, the peripheral nervous system, our sensory epithelium of the ear, the nose, the eyes, and skin develops, and this includes the hair and nails, pituitary, mammary, and sweat glands, and the enamel of the teeth. The paraxial mesoderm forms somatomeres, which gives rise to the mesenchyme of the head and organize into somites in occipital and caudal segments. Somites then give rise to the muscle tissue, cartilage, and bone, and subcutaneous tissue of the skin. The mesoderm also gives rise to the vascular system, which again includes the heart, also the urogenital system, as well as the spleen and the cortex of the suprarenal glands. The endodermal germ layer provides the epithelial lining of the GI tract, respiratory tract, and urinary bladder. It also forms the parenchyma of the thyroid, parathyroid, the liver, and pancreas, and finally the epithelial lining of the auditory canal and the tympanic cavity. To touch on the abnormalities that can occur during the embryonic development, we have abnormal implantation of the embryo. The clinical consequences then include an ectopic pregnancy, holoprosencephaly, caudal dysgenesis, renal agenesis, and an imperforate anus or situs inversus. During week 3 to week 8, abnormalities that are usually the failure of the closure of the neural tube on the dorsal aspect of the fetus, failure of closure of the ventral body walls, failure of closure of the pleuroperitoneal cavity, cardiac looping, formation of the cardiac septa, or formation of the lung bud, or breakdown of the anal membrane, all have clinical consequences that include anencephaly, spina bifida, ectopic cordis, congenital diaphragmatic hernia, dextrocardia, atrial and ventral septal defects, teratology of Fallot, and the tracheoesophageal fistula, as well as anal atresia. Developmental horizons during the fetal life. So taste buds appear around week 7, swallowing at week 10, respiratory movements between 14 and 16, and the sucking movements at 24. Some sounds can be heard at 24 to 26 weeks, and eyes become sensitive to light around 28 weeks. The next few slides just highlight the major milestones in the development of different organ systems, which we've already highlighted in the prior discussion. So here we have the pre-embryonic phase with all the developmental highlights from week 2 to week 4. Continuation of the pre-embryonic and embryonic into the fetal phase of development till week 12. And lastly, the fetal development until birth itself. Okay, to touch on the velocity of growth, at conception, the zygote length measures around 130 micrometers. It multiplies in its length and weight several times to reach the size of 35 to 50 centimeters and 2.5 to 3.5 kgs at term. Sorry about that. One of the most striking changes during fetal life is a relative slowdown in growth of the head. Fetal growth velocity, typically represented as deviation from the growth velocity charts, is particularly relevant for assessing fetal growth rather than fetal size. Studies have reported that reduced third trimester growth velocity is associated with an increase in incidence of certain adverse pregnancy outcomes, but the association of growth velocity in the earlier trimesters with adverse outcomes is still unclear. So up to 16 weeks, it's a very slow rate with less than 10 grams per week with regards to growth. 16 to 28 weeks has an accelerated growth with approximately 85 grams per week. And then 28 weeks to 37 weeks, here is our maximal rate of growth, nearly 200 grams per week. And then from 37 weeks to 42 weeks, it's a decelerated growth again, approximately 70 grams per week, until we reach term where we're about 2.5 to 3.5 kgs and 35 to 50 centimeters in length. This is just a table that summarizes the adequate length versus weight at a given gestation during the fetal period. Okay, factors that influence fetal growth. These are generally the fetal-placental factors, maternal factors, hormonal factors, and environmental factors. So genetic disorders account for about approximately 1/3 of reduced fetal growth, with a frequency of at least 20 to 60% of the risk occurring for fetal growth restriction. Is about 20 to 60%, and the risk of fetal growth restriction fetus having a congenital abnormality is 10%. It is important to note that growth impairment as a result of fetal chromosome abnormalities usually occurs earlier than impairment caused by the placental abnormalities. Other congenital anomalies associated with fetal growth restriction outcome are duodenal atresia and pancreatic agenesis, amongst others. Each of the named abnormalities show a marked reduction in the weight in comparison to the normal growth trajectory of a fetus. For example, trisomy 21, there's a 350-gram less weight, 350-gram reduction in weight, and there's a 4 times more likelihood of developing fetal growth restriction. With trisomy 18, the incidence of fetal growth restriction is 84%, and the reduction in weight is less than 1,000 grams. With trisomy 13, more than 50% are affected by fetal growth restriction, and the reduction in weight noted compared to the normal fetus is 700 to 800 grams. Turner syndrome is also associated with weight loss or weight reduction, with about 400 grams less than the average. Several genetic and congenital syndromes are associated with an increased incidence of macrosomia. The Beckwith-Wiedemann syndrome is frequently associated with macrosomia, usually due to pancreatic cell hyperplasia. Affected infants usually have hypoglycemia, macroglossia, and omphalosia. They may also have intestinal malrotation and visceromegaly. Other rare syndromes include Weaver syndrome, Nevo syndrome, and Fragile X syndrome. Congenital infections, chronic intrauterine infections are responsible for 5 to 10% of IUGR pregnancies, and the most common pathogen is CMV. Signs of congenital infections are nonspecific, but include central nervous system involvement. The most common protozoan infection is toxoplasmosis, but malaria is also associated with an impaired fetal growth. And although bacterial infections are usually associated with premature birth, Listeria is an exception and has been highlighted as a factor for impaired fetal growth. The placenta plays an important role in normal fetal growth. Placental weight has shown to have an effect on the instances of abnormal fetal growth, usually seen as smaller with fetal growth restriction and larger in size with a larger gestational age, suggesting that growth may depend on the weight and size of the placenta. Placenta previa, which is usually associated with fetal growth restriction, is unfavorable placental implantation. And infarcts usually are indicative of the fact that there's decreased functional exchange within the placenta to the fetus. Premature placental separation of varying degrees of placental abruptio may occur at any time during pregnancy, and they do have variable effects. Malformations of the placenta or the umbilical cord, such as single umbilical artery, velamentous umbilical cord insertion, placenta hemangioma or battledore placenta, are also all associated with fetal growth restriction. Chronic inflammation of placental villi is seen with increased incidence of fetal growth restriction, and uterine abnormalities may also be associated with impaired growth. With multiple gestation, this has long been associated with premature delivery. However, it is also associated with 20 to 30% of fetal growth restricted fetuses, mostly as a result of the placental insufficiency, triple TS, preeclampsia, or anomalies that may occur. Fetal growth has a direct relationship to the number of fetuses and the type of placentation, either monochorionic or dichorionic. Sex determination, well, usually at term, female fetuses are on average 5% smaller and 2% shorter than male fetuses. Fetuses being suspected for large for gestational age could possibly large secondary to constitutional factors. A large maternal stature should be considered as a contributing factor to macrosomia, as studies now show that there is a correlation between birth weight and maternal height more than weight with regards to macrosomia. Again, sex determination is important in assessment of large for gestational age. Like we mentioned, our male counterparts are genetically larger. With postdatism, this is usually a prolonged pregnancy state or period and is most likely to result in macrosomia, presumably due to continuous delivery of nutrients and oxygen to the fetus. Numerous maternal diseases are associated with suboptimal fetal growth. Hypertension is the most common complication during fetal growth restriction. With diabetes, whether it's gestational, chemical, or insulin dependent, it's also a condition classically associated with abnormal fetal growth, resulting in fetal macrosomia. Vascular disease and hypoxemia, diseases that affect maternal microvascular perfusion, can be associated with abnormal growth. These include collagen vascular disease, insulin-dependent diabetes, preeclampsia, and also maternal chronic hypoxemic states due to pulmonary disease or cyanotic heart disease is also associated with reduced fetal growth. Maternal weight at birth, pre-pregnancy, and weight gain during the pregnancy account for about 10% of the variance in fetal weight and increase the risk of delivering an infant of less than 2,500 grams. Excessive weight gain during pregnancy is also associated with macrosomia. With malabsorption, this predisposes a fetus to fetal growth restriction, and the most common clinical conditions include IBS, pancreatitis, and intestinal parasites. Maternal eating disorders such as bulimia and anorexia also are associated with fetal growth restriction. Oops, sorry. So when it comes to maternal features, stature is significant. A small mom may have a smaller than normal infant due to reduced growth potential. And these moms and infants are completely normal and healthy, but are constitutionally small due to genetic variation. On the opposite end, large statured moms have a high association with macrosomia, and obesity and increased BMI is associated with a 3 to 4-fold increased risk of macrosomia, and again is independent of comorbidities such as diabetes. Maternal parity exerts a modest effect on the birth weight of a fetus. And when it comes to lifestyle with drug exposure, both social and prescribed drugs can affect fetal growth. Cigarette smoking is much more common in the women of childbearing age and is the single most preventable cause of fetal growth restriction. Alcohol use is also associated with reduced fetal growth, and virtually all fetuses with fetal alcohol syndrome exhibit signs of growth restriction along with heroin use and cocaine. Pharmacological agents such as immunosuppressive drugs, anticonvulsants, anticoagulants, anti-anxiolytics, and some antihypertensives are also associated with increased incidence of fetal growth restriction, primarily as a result of the teratogenic effects. So fetal growth demands a coordinated increase in size of the fetus and the placenta, and both are determined in part by locally produced peptide growth factors. The availability of growth factors to individual tissues may be due to local changes in gene expression, but it is also controlled by proteolytic release from extracellular matrix stores. Membranes of the fibroblast growth factor family are stored within the basement membranes, while the insulin-like growth factors are stored in association with specific binding proteins. Insulin is a major trophic hormone in utero, and pancreatic B-cell mass is determined by locally produced insulin growth factor 2 and membranes of the fetal growth factor family. The two types of trophic factors that have shown to substantially regulate the growth of the fetus, especially in the second and third trimester, also contributes to female macrosomia is insulin growth factor and insulin. Insulin growth factor 1 is the major growth promoting factor during development, before and after birth. It has mitogenic and anabolic effects, and the fetal tissues express insulin growth factor 1, and serum levels are correlated with fetal growth. Mutations in insulin growth factor 1 gene result in fetal growth restriction. In contrast to the prenatal period, postnatal growth depends upon growth hormone, This hormone binds to its receptor, activating a signal transduction pathway and resulting in synthesis and secretion of the insulin growth factor 1. Mutation of this gene or hormone also is characterized with growth retardation. So exposure to ionizing radiation kills rapidly proliferating cells, making it teratogenic, and produces virtually any type of birth defect, depending on the dosage and stage of development at the time of exposure. With heavy metal exposure to metals such as lead and mercury could have been associated with increases in abortions and growth retardation, as well as neurological disorders. Assessment of growth. So assessment of fetal growth is essential as it provides us with critical information about the well-being of both mother and fetus. With assessment of growth, we are able to detect growth abnormalities, monitor placental function. It also assists with the assessment of maternal well-being or health, and assists us with a guide to the clinical management of a pregnancy. Most importantly, timely recognition and intervention can reduce prenatal outcomes such as mortality, prematurity-related complications, and long-term developmental delays and disabilities. There are several approaches to assessing fetal growth and development in utero, and these include dating, the SFH plotting, ultrasound assessments, as well as maternal serum screening, amniocentesis, chorionic villus sampling. In combination, these techniques are designed to detect malformations, genetic abnormalities, and overall fetal growth and complications of the pregnancy itself. It's imperative that a woman should seek medical assistance when she has either missed a menstrual cycle or is experiencing any irregularity of her cycles. A pregnancy test should then be performed and history taken with regards to her first day of her last normal period, so that this pregnancy can now be dated accurately as possible. This is sometimes not possible due to irregular cycles or the patient being unable to recall her dates, or the fact that she experiences any type of complications of bleeding during the implantation process. But the earlier a patient books, the certainty of dates and documentation assists greatly when dating a pregnancy, which is very essential. Our antenatal record book assists with documentation and continued assessment of the trajectory of the pregnancy. When booked, all the information has been gathered, and we are able to use the above to highlight risk factors and plan when and where this patient should be managed. We can also use it to prevent reoccurrence of bad outcomes and plan the frequency of assessments for both mother and child. It is really a practical and important tool for management and assessment of pregnancy for every mother. So here we have the growth chart, also present in the maternity case record, and this also assists with highlighting the trajectory of growth during the pregnancy. At every antenatal visit, patients should be examined and all abdominal findings should be plotted. The plotting of the SFH at every visit will highlight if the growth is normal, increased, or reduced. There can also be instances where we notice that the plotted marks may have plateaued or have been static for at least 2 recordings. This is indicative of the fact that there is some growth retardation or there's a slowing down in the rate of growth. And this should alarm the healthcare worker to send the patient for further ultrasound investigations, as well as look at a clinical picture to exclude any comorbidities that may be impairing growth. On the other hand of the spectrum, excessive growth can also be highlighted with this chart when we plot, and this too can alarm the healthcare worker for further investigation. So in summary, plotting and reviewing the first 2 pages of the antenatal chart is such a simple yet a very effective task, so we shouldn't overlook it. This is just to highlight the correlation of the SFH measurements to the actual gestational age of pregnancies for reference. So if you note, if the patient is 16 weeks and now she's palpating at 12, there's a problem. Ultrasound is a relatively non-invasive technique that uses high-frequency sound waves reflected from tissues to create images. The approach may be both transabdominal or transvaginal, and important parameters revealed by the ultrasound include the characteristics of fetal age and growth, presence or absence of congenital anomalies, the status of the uterine environment, which includes the amount of amniotic fluid, placental position, umbilical flow, blood flow, and whether multiple pregnancies are present or not. All of these factors are then used to determine the proper approaches for management of the pregnancy. So when we use ultrasound investigation, we generally look at the crown rump length, the biparietal diameter, femur length, abdominal circumference, and the estimated fetal weight is then estimated. Between weeks 4 and 5, we measure the mean sac diameter, but it's not used to assign a gestational age or estimated date of delivery for the pregnancy. We then use the crown rump length to assess and assign a gestational age and the estimated date. This measurement is used until 13 weeks and 6 days, where we have a measurement that does not exceed 84 millimeters. Hereafter, biometry is used for further fetal assessment. From week 14 to 24, pregnancy should be dated by measurements of either the head circumference or the femur length, and both parameters should correspond. No gestational age is assigned to patients seen for the first time after 24 weeks. In this instance, biometry is done to assess fetal size and not the gestational age, and will require subsequent examinations to assess the velocity of growth. So, how do we measure the crown rump length? We have to make sure that we have good magnification. The calipers are placed correctly. 3 measurements are usually taken, and the best of the 3 readings are applied to dating this pregnancy. So it's usually in the midline sagittal section of the whole embryo or fetus. We make sure that the fetus basically fills most of the width of the screen in a neutral positions with endpoints of both the crown and the rump, which should be clearly defined. We should avoid inclusion of the structures such as the yolk sac, and the amniotic fluid should be visible between the chin and the chest. Now you're ready to take your measurement. Dating by the head circumference. So once the crown rump exceeds 84 millimeters, dating is done by using the head circumference. This can be with or without the femur length from the mid-trimester onwards. So the correct anatomical plane for head circumference or BPD measurements is usually, again, cross-section at the level of the lateral ventricles. We should see the midline the falx cerebri, and the midline should be equidistant from the upper and lower parietal bones, with the CSP visible. Should be bisecting midline 1/3 from the sincipit itself. The head structure itself should be rugby football shaped, rounded at the back and more pointed at the front, and the skull contour should be regular for us to do a correct measurement. This is just another picture depicting the same head circumference and BPD planes. For the femur length, both ends of the ossified metaphysis should be clearly visible, and here the longest axis is measured. So assigning gestational age accurately requires the accurate head circumference and femur length to correspond, the measurements to correspond. And in instances where they don't correspond, it is important to review the head circumference and the femur length sections, as well as caliper placements. We should be repeating sections and remeasuring, and consider if there is any significance of genuine discrepancies. The correct anatomical plane for the AC measurements usually is transverse section of the fetal abdomen. We should visualize the stomach bubble, and the kidney should not be visible, and there should be ribs visible on either ends of the ellipse that we bring out for the abdominal circumference. Like I mentioned, it should be an ellipse, or we can do linear measurements that include the anteroposterior diameter or transverse abdominal diameter. And these diameters should be at least 90 degrees to each other, from the outside of the abdominal circumference to the other end, so outer to outer. To assess the size and weight of a fetus, we can either use the AC measurement alone or in conjunction with the head circumference. These two in conjunction with the femur length, and then lastly, we can add on the BPD to the 3 prior measurements that we have, the AC, HC, and the femur length. So this slide represents the 4 graphs illustrating international standards for fetal growth based on serial ultrasound measurements. These standards are derived from the fetal growth longitudinal studies of the Intergrowth 21st project. Each one of these charts display an expected range of growth according to the specific gestational age. We are then able to use the lines representing the 10th, 50th, and 90th centile to assess the distribution of these measurements and assess if the fetus is growing within expected range of the specific gestation. Just to touch on the Integral 21st project, this was a multi-country, multi-center study aimed at developing new international population-based growth standards for fetuses, newborns, and preterm infants. It was conceived to address the limitation of existing growth charts, which were often based on populations from developed countries and might not accurately represent the global diversity of fetal health and infant growth. In essence, it basically provides a robust, evidence-based framework for assessing fetal and infant growth, contributing significantly to maternal and fetal health worldwide. These are the twin pregnancy growth charts developed from the Fetal Medicine Foundation. These provide chorionicity-specific reference ranges for fetal growth in twin pregnancies and is used to improve accuracy in assessing fetal growth restriction and prematurity risks in twins. So the key findings: twin fetuses grow differently from the singletons, and especially as the pregnancy progresses itself. The monochorionic and dichorionic twins showed reduced growth compared to singletons, and the growth divergence becomes more pronounced after 21 weeks of gestation. So using singleton growth charts as a reference helps standardize fetal growth classification. The Fetal Medicine Foundation charts allow for comparative evaluation between singleton and twin pregnancies. So here, for the next few slides, is just the tools that we use at our facilities to assess the trajectory of fetal growth. After multiple studies done, a conclusion was made that suggests the use of the same set of tools for dating, biometrics, and estimated fetal weight. This is important and should be favored over heterogeneous references of diverse origins. This helps to optimize screening and is essential to standardizing it's essential to use standardized tools, as this limits the possible bias that can occur. Okay, so fetal ponderal index. This is a predictor of adverse neonatal outcomes in low and high risk women. There is no evidence that suggests it being superior to estimated fetal weight in identifying a fetus at risk for prenatal complications or growth restriction. It is also controversial if a fetal ponderal index adds value in differentiating SGA from fetal growth restricted fetuses. With interval growth, this assists in differentiating normal from abnormal growth if gestational age is uncertain. So assessment of the AC interval growth is commonly used in the clinical setting. So how often should we be doing assessments? A routine mid-trimester scan is performed between 18 to 22 weeks, and this period represents a compromise between the dating of the pregnancy and timely detection of major congenital anomalies. The interval between scans should typically be at least 3 weeks to minimize false positive rates for the reduction of fetal growth disorders, although this recommendation does not preclude more frequently performed scans when clinically indicated. At least a minimum of 2 scans should be performed in a normal pregnancy with no complications. The need for any additional scans is based on local guidelines and the presence or absence of maternal or fetal conditions and risk factors or related findings that are known to be associated with abnormal growth. It is important to note that exposure to ultrasound should comply with the ALARA principle, which is as low as reasonably achievable. So this table basically is an algorithm that I found in one of the articles that we were going through with regards to fetal growth surveillance. So like we've mentioned, patients who are low risk with no known risk factors, we can do serial measurements 2 to 3 weekly, monitoring of the SFH at every single visit that she has until her delivery, and then monitoring and checking the growth chart to see if the plotting is showing a good growth trajectory. If not, then we send her across for further investigation, and that generally includes the ultrasound, glycovolume, umbilical artery Doppler assessment, as well as the estimated fetal weight. With patients with increased risk, with either maternal risk factors such as advanced maternal age, smoking, drug use, or previous pregnancy history that is highlighted, previous stillbirths, preeclampsia, previous SGA babies, or if she has significant medical history like hypertension, diabetes, autoimmune diseases, or renal impairment, or if she's unsuitable for assessment at a base institute, being maybe due to uterine findings or increased BMI. These patients should be treated as high risk and should be assessed at a high-risk institute where we do serial assessments, initial anatomical scan, and then in periods of 1 to 2 weeks of assessments with regards to each individualized condition or risk factor that she may experience during the pregnancy. Other antenatal strategies for fetal assessment includes the biophysical profile, where we score to check whether the central nervous system is functional and the fetus is not hypoxemic. This also assists us with deciding whether we need to act and deliver or provide any further treatment to the mom during this pregnancy. The non-stress test is also one of the additional assessments antenatally that's used. Twin births continue to be a significant source of perinatal morbidity, mainly due to the complications of preterm birth, with approximately 20% delivering before 34 weeks and up to 80% delivering before 37 weeks gestation. In addition to preterm birth, twin pregnancies have higher rates of hypertensive disorders of pregnancy, gestational diabetes, cesarean section delivery, congenital anomalies, genetic abnormalities, and stillbirth. Multi-fetal pregnancies have different growth trajectories than their singleton counterparts. Another common occurrence at the time of delivery in twins is a low birth weight, and this leads to further increase in morbidity and mortality. So twins have been traditionally referred to as monozygotic and dizygotic, and although this is academically intriguing, the more important distinction is the chorion and the amnion number for the twins. Hence, we refer to the twins as either DCDA, MCDA, or MCMA. This distinction is important as each version of twins come with their own unique set of complications. Ideally, assessment for above is done in the first trimester once the pregnancy has been confirmed. So first trimester evaluation, with size discrepancies, we generally focus on the discrepancies measured at 7 weeks, taking the crown rump length at 7 weeks, that measurement. So the CRL is expected to be concordant amongst all twin pairs, and significant discrepancies in the CRL are usually associated with fetal loss that occurs around the 11 to 14 weeks gestation. Studies done show that discordance of less than 20% have a 0.8 to 4.5% of single fetal loss at 11 to 14 weeks. More than 30% have a rate of 45% of single fetal loss, and some studies have even shown that a 10% discordance has led to adverse outcomes such as preterm delivery, low birth weight, and birth weight discordance, as well as fetal structural anomalies. Hence, counseling and evaluation of genetic abnormalities and structural abnormalities may be warranted. An NT scan is performed between 11 to 14 weeks. This is common for genetic screening. With second trimester evaluation, an anatomical scan is done at 20 weeks. And evaluation of the fetal size is common in all pregnancies. So like I mentioned, the fetal anomaly scan is done at 20 weeks. And then we define discordance in growth as a 15 to 25% difference in estimated fetal weight. Multiple studies have failed to show any association between discordant birth weights and adverse outcomes, and these same results were seen even when separately analyzing dichorionic and monochorionic twin pairs. It is common to find a condition known as selective IUGR starting in the mid-second trimester. So surveillance can be done every 4 to 6 weeks in the absence of fetal growth restriction and pregnancy complications. Between 30 to 32 weeks, there's a reduced trajectory that is seen, and it's not necessarily a sign of pathology. In fact, the slower the trajectory, it's actually helpful for physiological adaptation of the twins with regards to the nutritional management in its attempt to not overdistend the growing uterus itself. Blick-Stain breaks the growth in twins into 3 phases. So we have phase A, which is from early pregnancy to 28 weeks. The growth trajectory is the same as singletons. Phase B starts at 30 weeks. the decreased birth weight in twins, there's a decreased birth weight in twins compared to singleton. And phase C is from 32 weeks to birth, where the weight difference between twins and singletons plateau. This theory emphasizes that in twin pregnancies, gestational age is prioritized over the size at birth. Third trimester fetal weight discordance does not necessarily predict adverse outcome, but does represent physiological adaptation to multiple gestation. Complications of the multiple pregnancies. So monochorionic twins, they have the highest rate of complication due to the disease process specific to sharing a placenta. And these includes twin-to-twin transfusion syndrome, sorry for my error there, and twin anemia polycythemia sequence, selective IUGR. We can get fetal cardiac anomalies, which are more common in the monochorionic twins of all types. And the monochorionic monoamniotic twins also have a high incidence of morbidity and mortality as a result of more frequent fetal anomalies, triple TS, TAPS, and cord entanglement. Dichorionic diamniotic twins, their complications primarily attribute to preterm birth. However, they are also more predisposed to a full range of obstetric complications. These complications are usually due to almost inevitable placental vascular anastomosis occurring between the halves of the monochorionic placentas. So how do we manage these obstetric complications or these births or these twin pregnancies itself? So with the dichorionic diamniotic, in uncomplicated cases, delivery is at 38 weeks. If there is any complications that are now highlighted or diagnosed, these cases now become individualized with regards to their therapy. With monochorionic diamniotic, it's the same, uncomplicated, we deliver at 37 weeks. And then if there are any complications, we manage individually or individualize the therapy for treatment, further plan management for these patients. With monochorionic, monoamniotic, uncomplicated, we deliver between 32 to 34 weeks. So in dichorionic twins, selective IUGR is treated similarly to singleton pregnancies, where Doppler studies and increased antenatal surveillance is instituted. However, since the fetuses do not share placenta, evaluation can be done separately when selective IUGR is present and doesn't necessarily pose a risk to the healthy fetus. A meta-analysis done showed that when demise of one twin occurred, the risk of co-twin demise was 4% in dichorionic twins and 12% in monochorionic twins. Delivery timing should be based on the severity of growth restriction, gestational age, and other factors. And if the demise of a fetus is imminent and the pregnancy is either pre-viable or very preterm, then expectant care may be appropriate to optimize the outcome for the non-growth restricted fetus. At a later gestational age, medically indicated delivery may be appropriate to optimize the outcome for the selective IUGR twin, despite causing preterm birth of the healthy twin. So with monochorionic twins, the death of one twin has a significant risk of death and neurological injury in the co-twin, being 41% for the death occurrence and neurological injury being 20%. The rate of brain abnormalities is 43% after birth if the co-twins survive. The latency period from absent to reverse end diastolic flow with monochorionic twins is 54 days. It's noted to be 30 days in dichorionic and 11 days in singletons. This is likely due to the early age of onset and placental connections that complicate the traditional pathophysiology of fetal growth restriction. So, Gratos and colleagues have established a staging system to describe selective IUGR in monochorionic diamniotic twins. We have type 1, which is defined by the presence of forward end diastolic velocity in the umbilical artery. This type does not deteriorate over the course of pregnancy and rarely results in stillbirth. Type 2 has consistent absent or reverse end diastolic flow, and this type showed in utero deterioration in more than at least 90% of pregnancies. Type 3 is absent and reversed end diastolic flow, seen alternating over a short period with forward diastolic velocity. This showed high rates of unexpected fetal demise in both the fetuses. With regards to management, it could be expectant, delivery, and selective reduction. Type 1 and type 2 are managed similarly to singleton pregnancies, with type 1 routinely managed as an outpatient. So here, Dopplers are done every 2 weeks and weekly antenatal testing with delivery depending on the testing results and the gestational age. Type 2 also frequent Doppler studies when fetus reaches a gestational age where it can now survive outside the womb. The frequency of testing is now increased to weekly, and if absent or reverse end or abnormalities of the ductus venosus is noted, then delivery is considered. With monochorionic twins, where there is a high risk of spontaneous death or pregnancy is preterm or survival selective feticide may be an option with the goal of maximizing the outcome for the larger fetus. With type 3, a selective feticide is considered, and close monitoring of deterioration is done with 8-hourly CTGs and weekly Doppler studies to pick up deterioration before demise in order to deliver the co-twin and avoid spontaneous death of the co-twin. Selective IUGR and triple TS. So here, performing fetoscopic laser photocoagulation for selective IUGR in the presence or absence of twin-to-twin transfusion syndrome has similar outcomes. The survival of the larger twin is reduced when fetoscopic laser photocoagulation is used for selective IUGR versus triple TS. Radiofrequency ablation showed better results in the survival for the larger twin with selective IUGR. The fetal reduction showed to be the most preferred method to increase the survival of the larger twin when triple TS is not present. One of the greatest challenges encountered in obstetrics is the management and complications seen in triplets and higher order multiple gestations compared to the singleton and the twin gestations. They confer significantly greater risk for preterm birth and low birth weight deliveries. Impact on maternal health in higher order pregnancies result in higher rates of anemia, postpartum hemorrhage, hospitalization, and time lost from work. The purpose of multi-fetal pregnancy reduction is to reduce the number of fetuses early in the gestation to be able to optimize the outcomes and decrease morbidity or mortality in the survivors of the higher order pregnancies. This is done by reducing the amount of fetuses in the gestation or pregnancy. This process is usually used when there are 3 or more fetuses present, and the pre-procedure considerations should include the relationship of the gestational sac to one another, chorionicity, fetal anatomy, aneuploidy markers, and also determining which fetus is more accessible to the chorionic villus sampling and reduction procedures. So, does size matter? So an AGA fetus is one whose size is within the normal range for its gestational age, and they are typically, they typically have individual biometric parameters or estimated fetal weight between the 10th and the 90th centile. Small for gestational age fetus is one whose size is below the predefined threshold for its gestational age, and its features typically have an estimated fetal weight or abdominal circumference below the 10th centile, although the 5th and 3rd centiles have also been used for cutoffs in literature. The lower the cutoff of AC and estimated fetal weight, the higher the risk of true fetal growth restriction. A recent Delphi consensus proposed that a cutoff of the abdominal circumference or estimated fetal weight below the 3rd centile may be used as a sole diagnostic criterion for fetal growth restriction. In cases of the AC or the estimated fetal weight below the 10th centile, the diagnosis of fetal growth restriction should be considered only in association with other parameters, depending on the gestational age, the uterine artery Dopplers, and the estimated fetal weight on the serial scans. Fetal growth restricted fetuses is one that has not achieved its growth potential, and the condition can be associated with adverse perinatal and neurodevelopmental outcomes. It has been classified into early, before 32 weeks, and late onset after 32 weeks. And fetuses suspected with fetal growth restriction will not necessarily be SGA delivery, and a fetus may fail to achieve its growth potential despite not being SGA at birth. Similarly, not all SGA fetuses are growth restricted, are most likely to be constitutionally small. Low birth weight, This is characterized as weight less than 2,500 grams or less than the 10th percentile value at 37 weeks. Large for gestational age, this is above the predefined threshold for the gestation, a specific gestation. Here again, estimated fetal weight or AC is above the 90th, can actually be above the 95th and the 97th centile as well. So what do we do in cases of abnormal biometry? So abnormal biometry, like we've mentioned, should trigger referral for detailed assessment of this fetus. And this should include confirmation of accurate dating of the pregnancy, assessment of potential factors that may have resulted in abnormal biometry, including the maternal factors. Detailed evaluation of fetal anatomy and consideration of karyotyping should be made. An evaluation of uteroplacental insufficiency, including all of the Doppler studies, and the objective placental morphology assessment should be done looking at the location of the cord insertion, the size and the appearance of the placenta. By this point, when we've made our diagnosis, either being SGA, FGR, or large for gestational age, our screening and risk stratification as well as diagnosis is now made. And as per our local guidelines, most importantly, we should be advising our patient on lifestyle changes, rule out preeclampsia regularly, and use the non-stress test as an additional assessment tool. Our umbilical artery resistance index, or PI, should be the primary surveillance tool for SGA at an early gestation, which is usually at 32 weeks. If positive in diastolic flow with RI or PI less than the 95th centile for gestational age is found, then an assessment of the ductus venosus is not indicated. If the estimated fetal weight is more than P3 but less than the 10th centile, we repeat the blood pressure, check the urine again, and do Dopplers 2 weekly, again to exclude any maternal factors. If all remains normal, we can assess the growth again at 36 weeks, perform a CTG. If it's still fine, we can go on to deliver at around 40 weeks. If the mid-cerebral artery was assessed and the PI or the CPR or plasma cerebral placental ratio was less than P5, twice weekly CTGs are required, and we should deliver at 37 weeks. If the growth rate is noted to be slow and the estimated fetal weight drops below P3 or oligohydramnios develops, but the CTG is still reactive, we can continue to deliver at 37 weeks. Unless if there is a persistent non-reactive CTG, and then we should deliver immediately. With the estimated fetal weight less than P3, we repeat the blood pressure, the urine, and Dopplers again 2 weekly. And if all remains normal, reassessment at 34 weeks is indicated. If that's still normal, we can reassess again 2 weeks later at 36 weeks and deliver at around 37 weeks gestation. If we note that the growth is slow or oligohydramnios is noted and the CTG is reactive at 34 weeks, we can do twice weekly CTGs, and reassessment weekly should be performed with a delivery plan for around 37 weeks. Unless the CTG is non-reactive, then we deliver straight away. With a viable fetus and umbilical artery pulsatile index of more than P95, we do twice weekly CTGs, reassess clinically for signs of preeclampsia and manage accordingly. The Dopplers and Leica is assessed weekly, and if absent or reverse end diastolic flow does not occur, we continue with our surveillance and deliver 37 weeks. With absent end diastolic flow, we arrange for delivery if it occurs at diagnosis at 34 weeks. Excuse me. We can consider steroids and magnesium sulfate if less than 32 weeks for neuro protection. Then we can continue with clinical assessment, which is required every 2 weeks, and ductus venosus should be added to our Doppler studies at this point. In this instance, delivery should be no later than 34 weeks, but can occur earlier if there are aggravating factors that develop, or if there's persistently abnormal Dopplers with the DV flow or pulsatile flow, and if there's a pathological CTG. With reversed end diastolic flow, we should arrange for delivery if diagnosed at 32 weeks, again considering MagSelf and steroids. If not, then twice weekly assessments, daily CTGs. We should be having this patient as an inpatient with twice weekly Doppler studies. If the DV is normal, we can deliver. No, sorry, with normal DV, and if the CTG is normal, then we monitor and reassess within 12 to 24 hours. But if there is an abnormality that we note, or if the CTG is abnormal, then delivery is imminent. Complications with fetal growth restriction can include maternal, fetal, and neonatal and long-term complications. These include the complications due to the underlying disease. With fetal complications, it's stillbirth, hypoxia, acidosis, and malformations. With neonatal complications, these include hypoglycemia, hypocalcemia, hypoxia, acidosis, and others. And with long-term complications, these are usually the lower IQ, learning and behavior problems with major neurological handicaps, such as seizure disorders, cerebral palsy, mental retardation. So once large gestational age is detected antenatally, the main focus is the timing and mode of delivery. The role of C-section delivery for fetal macrosomia has been debated, and it does appear to be associated with the reduced risk of adverse neonatal outcome, which is mainly birth trauma. However, the number needed to treat is very high. RCOG guidelines recommend elective cesarean section should be considered for women with diabetes, where the estimated fetal weight is more than 4.5 kgs, and this is in an attempt to reduce morbidity. Induction of labor at term was also recommended to reduce shoulder dystocia, but at the time of the development of the guideline, it also suggests that IOL in patients who are non-diabetic didn't prevent shoulder dystocia. NICE guidelines suggest that women should have a comprehensive discussion regarding the birth options, including expectant management, induction of labor, and elective cesarean section. They also acknowledge that whilst the overall benefits and risk of induction of labor compared to expectant management is unknown, the risk of shoulder dystocia is reduced with induction, with approximately 270 per 10,000 more cases of shoulder dystocia occurring in the expectant group compared to the induction group. So with LGA, like we said, it's more than the 90th centile for a given gestational age. We confirm the diagnosis with our at least more than 2 weekly, well, it should be more than 2 weeks larger than the date, or with plotting. We have to make sure we exclude that a wrong date wasn't used for actually dating the pregnancy. We should be taking a history to make sure we're not missing a multiple pregnancy. Check the mother's physical condition as well with regards to the obesity, her height, her stature. Investigations should include doing infective screening as well as oral glucose tolerance test, and then the scan to obviously assess for further management. Then the management will include managing the acute complications at presence, controlling the diabetes if there is, and dealing with everything else that we find at that point of assessment. I'm almost done, Prof. Almost done. 2, 3 more. So complications of large gestational age, we have maternal, fetal, and neonatal complications with long-term complications as well, which I'm not going to go through because of time. But the key points in management basically for abnormal growth is make sure we check the gestational age versus the rate of deterioration. There should be a timed delivery put into place with inclusion of the multidisciplinary team, and neonatal support is essential in these type of pregnancies. We should be considering the mode of delivery, and which is much more feasible, NVD versus Caesar. It should be a priority when considering the mode of delivery, and a Caesar is indicated if there is an obstetric indication itself. With regards to neonatal support, we should be thinking about where we should be delivering this patient. Does this patient or the babies require tertiary specialities, such as peds or cardiology? Should we be referring to our tertiary institute? So the take-home message is fetal development is a stage-specific and time-sensitive aspect. Each trimester contributes uniquely to viability and health, and continuous monitoring is essential for early intervention. Thank you.
It's like a mouthful.
Ooh.
Let's take one or two comments on the floor. Are there any questions or comments?
The only comment is that she was too expensive. Things could have been brought closer. She spent a lot of time and
Really?
maintenance on the just even pre-fertilization. So she took us through the ovulation, blah blah, which is not. There was significant parts of the talk that were not belonging to this, and there was a lot that you said with your mouth that was not on the slide, so you left us for our imagination. But well prepared, I must give that to you. Did a lot of homework. I think it was Dr. Kumalo's duty to narrow you down. So I think, they say one slide per minute. I'm not sure how many slides you had. In addition to the many slides, there was double the volume that was outside the slide. So that in itself was meant to take us forever. But well done. I think this was a very important talk for us to understand, the basics of fetal growth. We hardly pay attention to. It's a shame that people can go through training and never actually understand. Just do SFA, and blah, blah, blah. So it took us nicely through that. But we could have trimmed it down so that we don't get lost in some of the things, but well done. Yeah. I'm not sure if
Yes,
all of
Thank you, presenters. Again, well prepared. The slides were very nice as well. Please just advise us on a patient who has taken cytotec, and it's a failed medical TOP, and now they've changed their mind and they want to proceed with the pregnancy.
Is it part of this talk?
I think it's not.
No.
It's not.
In 2 hours' time, we will bank that question. I think we are at quarter to. We've got the Fatima from Pfizer. I don't have a lot. It does, but what some nice things. But just as we start the month of August, last week we spoke about time and keeping time. When we started the talk, there was no register except of the young guy. The one who gets If we left today at 10 to 7 and you arrive here 10 minutes late, adjust your clock. Wisdom says so. We don't have to tell you what time you leave your house. You know where you stay. You know what traffic you come through. We can't be talking